Welcome back to another episode of The Learning Curve. I am your host, Dr. Irtaza Asar, and today's episode is one that I've been looking forward to for a long time. In resuscitation medicine, we spend a lot of time teaching what to do, the airway steps, the lines, the algorithms, the checklists. But the truth is, technical skill alone doesn't make a resuscitationist. The real foundation, and the part that we rarely name explicitly, is the mindset behind the actions. This includes the way we think, the way we prepare, the way we make decisions under uncertainty, and the way we recover after that dust settles. To explore this inner architecture, we're joined by someone who has fundamentally reshaped how an entire generation approaches critical care, Dr. Scott Weingart. He is the resuscitationist and also the voice behind EMCrit. Today, he's going to share his expertise and help us with a rather difficult question. What if the most important resuscitation tool isn't a device, a drug, or a procedure, but really your own mental framework? In this episode, we're going to dive into the origins of the resuscitationist mindset, how to develop architecture early in training, and the balance between action and reflection, and why cognitive humility may be the most underrated skill we teach. So let's get to it. Scott, thank you so much for joining me today, man. I really appreciate your time.
Oh, it's a pleasure. I'm so excited to talk about these topics.
I think it's going to be really fun, man. And I think we were just talking about this before we started recording. I always think of this as almost like a blind spot in medical education where we teach residents a lot about the art of medicine, but then quite often we tend to forget about how to teach residents on how to think about thinking. So I think this is going to be really fun, and I'm really excited to pick your brain about this. So before we dive into this, and before we talk about the actual idea of how to teach this mindset, we have to talk about where it comes from, right? Before Batman, there was Bruce Wayne. Before Spider-Man, there was Peter Parker. There's got to be an origin story, right? So every resuscitationist has a set of early experiences, mentors, mistakes, key moments that really shape the way they think under pressure. So let's start there. The origin story. So Scott, talk to me about where this resuscitationist mindset actually started for you, what it means to you, and where did it all begin?
Sure. So I had majored in college in philosophy and psychology, and that's where I thought my eventual career path was going to go. And then medicine was kind of dropped in my lap when they came on campus and recruited. But I still love those two sets, those bodies of knowledge. And I was kind of yearning to explore those. So that's one thing that was just primed in my brain. But then throughout emergency medicine training, I knew I wanted to go into critical care before I even entered it. But I did not see the mindset that I was hoping for amongst my attendings, my role models. And they were fantastic. They were amazing doctors, but just not this mindset I had built up in my head of this is how it should be from all those philosophical investigations until I had gone into critical care fellowship at the Shock Trauma Center. And there, the head of that place was Tom Scalea. And he had built a culture that I'm like, this is it. This is the mindset I've been looking for. And to describe it, it was these were the sickest patients in the world. No one is sicker than the patients that came to that center. And yet the resuscitations, the critical care interventions were all done while people were cracking jokes, while they were calm and relaxed and had the bandwidth to be able to really observe everything from a remove. There was no anxiety. There was no, and of course, I'm probably like glossing over the sharp corners here, but from my recollection, there was not a single time I saw these people lose their cool. And so it was this effortless pursuit of excellence, what in Taoism is called Wu Wei, was what was being really exemplified by their mindset. And I'm like, this is it. I always had this yearning to find something like this, and I found it in this place. And then I said, if it could happen there, then it probably could be externalized to other places. And that kind of became a career path.
Gotcha. So there you have it. That's the origin story. So for everybody that's always wondered about where that mindset comes from, there it is right there. So now, Scott, now that we've established where this came from, the next challenge is really to get a sense of where and how it plays out in real time, right? So that's in that messy, chaotic resuscitation. Because, mastering resuscitation isn't really just about what to do. It's when do you move, when do you pause, and really that tension between acting and thinking. And that's one of the hardest skills for trainees to learn. But I also think about it from an educator standpoint. That's also one of the hardest skills to teach. So how do you teach that balance, and how do you help residents understand that, hey, speed saves lives, but you also have to slow down because that's actually what's going to prevent harm?
Yeah, I mean, one of the foundational mottos of EMCrit has always been slow is smooth and smooth is fast. And that comes from the military. And it embodies so much of what your question is alluding to, because I don't think you teach speed. Speed comes from a foundational excellence, and you build that up, and then you just naturally get faster. If you're searching for speed, you're going to fail, because externally induced speed leads to error, and error leads to a true loss of speed. So the way to go fast is just do everything right. And there's a piece of that where you can speed up and you can teach how to speed up, and it's really to eliminate extraneous steps. So that is something that can be taught. So you could tell them, look, if you're going to need a crash central line, here's the 3 things you need to touch in the kit to get that in, versus the 17 other steps you could do that are superfluous. And so you teach that, you teach where to position the tray so that it's on their dominant hand. All these things that could be cut out, that makes people quicker. And that mindset embodies a real path to speed. But the way people think they could get quicker, which is going faster on the actual steps, whether cognitive for decision making or procedural, is the worst way to get fast. That's just prone to error. It just, in the midst of chaos, you're already adrenalized. So what you think is going a normal speed is already sped up. So I would say teach slowness and teach how to cut out extraneous steps, and then speed comes naturally.
Absolutely. And that's something that I've tried to impart on my residents as well, especially the younger learners where they're doing crash central lines or some other kind of high stakes procedure. And I say, hey, listen, the procedure itself, try to do as slow as possible, because the faster you try to do it, the more your fine motor skills will deteriorate. And as that adrenaline is pumping, your hands are starting to shake, that needle control, you're going to start to lose that. There's other parts where you can try to speed up, like your preparation of the catheter, opening up the kit, getting gowned up, getting dressed, because really there has to be a sense of urgency there and you don't want to be spending too much time. But then the actual act of doing the procedure, whether it's, let's say, central line or intubating, take your time. Prep yourself for success, control your emotions, control your adrenaline as best as you can so that you can do this successfully. So I think that's actually a really great overview. Are there certain frameworks that you use for decision architecture in a crisis? Things like pre-commitment, mental rehearsal, cognitive offloading. Can you talk to me a little bit about that?
Sure. So the architecture I like to build is trying to speed up the natural process that occurs. And the natural process that occurs from a cognitive standpoint is the chunking of large disparate amounts of stimuli into patterns. And then those chunks are actually incorporated into either illness scripts, which are your recognition priming, or treatment scripts, which are your interventions once you've actually identified a list of possible etiologies for whatever's going on in front of you. So the best architecture I could come up to is to make that a external process as much as possible, to start asking yourself the question, and really it doesn't need to go too far beyond just simply asking yourself the question of, okay, so I eventually found out the thing I just saw that was this chaotic resuscitation, that I'm really not even fully on board with what took place yet. My attending was doing a lot of it. I was early on in my career. And okay, well, what did it turn out to be? Let's backtrack now and actually look, okay, what were the cues to that actually led her to know that's what this is and start treating? Okay, how did she know to do 7 things at once? She was calling for all these meds and doing these things with her hand at the same time. Okay, where did that come from? Massive things get immediately spewed out of her mouth. And you could actually ask. You don't have to do this purely on, your own self-reflection. You could say, all right, how did you know that was scape, from the moment, because I was like, okay, they look like they have severe shortness of breath, but I don't know, what could it be? Is it severe COPD? Is it asthma? I don't know. And, but my attending, she's like, this is scape. Let's start, getting the nitro. Okay, what made for that immediate recognition? And they'll tell you if they have metacognitive awareness, they'll tell you, okay, well, let me think about it. Because as you develop on towards expertise, a lot of experts lose the capability of actually having system 2 explanations for what they were doing. So you want to go to that attending is a good teacher. What makes them a good teacher is they still remember, or they've backtracked and relearned the actual breaking up of all those things, that illness script, et cetera, back to the pieces. And those attendings, you go to them and say, what did you actually see? And they'll tell you, well, they were sweaty and their blood pressure was super high. And there's not too many things that make you sweaty and clamp down and your blood pressure is super high with shortness of breath, right? And so that you're like, oh, okay, well, that's something I'm gonna look for. You kind of externalized an illness script, but it's not safe yet. And the reason why it's not safe is the other thing that they've incorporated that you might want to ask about is what could be anomalous in those situations? How am I going to get burned? Where is going to be a situation where they have those same things you named, and yet it's not going to turn out to be escape, right? That's the safety mechanism of building safe heuristics is taking in all the stimuli that points you towards something and then asking the question of how am I going to get burned? What are the anomalous signs that are going to tell me it's not that, even though a lot of the pieces of it feel like that? So that's just one cognitive architecture that I recommend people use.
I love that. And I've actually started doing something where when I teach residents about the concept of illness scripts, I tell them, hey, when we start to shift into that type 2 thinking, ask yourself, does this patient actually fit what I have developed as an illness script for this disease, right? So this COPD exacerbation that's acutely wheezing, you've done 3 nebs, you've done steroids, you should start to see some improvement. And yet they're still persistently tachycardic. My illness script is, hey, you do nebulizers, you do steroids, you do BiPAP, you should start to see some improvement. Now the question is, why is this not fitting what I'm originally thinking? And you're taking that cognitive pause to stop, think, reassess the patient and see if what you're doing actually works, right? And then you kind of think to yourself, well, maybe this could be a PE. Let me go back and reassess the patient and see, hey, did you recently have surgery? Oh, you had recent surgery? Okay. Maybe this might be a patient that I might consider a CT angio because anywhere from 8 to 12% of COPD exacerbations are due to PE. So now you're starting to rework what you're thinking because primarily you ask yourself, hey, did this actually fit that original illness script pattern that I had, and it didn't. One of the things that I've also been a huge fan of, and that's become part of my decision architecture, is this idea of pre-committing. I guess the best analogy that I can think of is the idea of like the post-ROSC bundle, where so backtracking, the idea of pre-commitment is you're sacrificing something in the short term to basically get more of a long-term benefit for. So you get ROS back, everybody in the room thinks, oh my God, we're done, but now you're going to try to forego that. Because the short-term reward is you feel emotionally, hey, I'm done with whatever, I've gotten ROS back, I'm done. But in exchange for that, what you're trying to do is, hey, the patient has a pulse, now we have to initiate our post-ROS bundle. That means I want vent settings, I want pressors, I want the glucose, I want temperature, I want the neuro exam, I want the disposition, I want to get my specialists on board, whether it's cardiology, whether that's my intensivist. Because ultimately what I'm doing is I'm foregoing that short-term idea of I'm done to now I'm working towards that greater reward of trying to maintain that neurologically intact survival. And that's really important to me. Another big decision architecture for me, and I wanted to pick your brain about, is mental rehearsal. How does that play into your resuscitation mindset?
Yeah, there should be a continuous capability of using what my friend Cliff Reed calls the most high fidelity simulator available, which is mental visualization, or if you're aphantasic, whatever thought processes allow you to recreate in your mind the events that happen. And that could happen before or after. So mental rehearsal would allow a true preparatory period. And the key to mental rehearsal, and we actually put this in our just-in-time physiologic preparation for decisions under stress, work with Mike Loria, was a key to mental rehearsal is to visualize success. And this gets left out. People visualize the steps of putting in a chest tube, but they don't visualize that it slips in perfectly. And then the elation that comes afterwards. From the athletic literature, this actually is markedly more effective than without that real success elation end to a mental rehearsal. So you could do it just in time. You have a procedure, you walk through the steps. You could do it ahead of time, which we highly recommend. Now we've actually incorporated this idea of mental rehearsal and mental simulation for high acuity, low opportunity procedures on a calendared appointment basis. So Sarah Gray actually had us now each month, whatever day you want it to be, maybe the first of the month is the easiest to remember. Okay, well, today is Crike Day. Well, now mental rehearsal of that is going to allow you to actually do 100 of them, seeing the steps. And then, you could actually then add in the 3D printed simulator and actually bolster that with hands-on. But a lot of things you can't actually do the hands-on. You're not going to do a resuscitative hysterotomy hands-on. And, more than once a year if you're lucky because your sim group is good and they do a day of that. But the rest of the time, it's going to have to be mental. So that's fantastic. And I think people could really get on board the procedural side of it. But the cognitive side is fantastic as well. The running of a resuscitation and actually picturing, all right, you add in these distractors. Okay, the nurse is, fresh out of school. There's the surgeon who belligerently is yelling over your shoulder, and you start mentally rehearsing how you're going to speak, how you're going to stay calm. And that is just as potent as how to walk through a thoracotomy.
Absolutely. And, funnily, you bring up the resuscitative hysterotomy example. And I actually just gave an OB lecture to my residents, and we practiced on a mannequin that I had built for resuscitative hysterotomy. And before I started the actual procedure, I told the residents, hey, I sincerely hope that you never have to do this. And it's very, very hard to prepare for something like this. But trying to mentally rehearse to yourself and putting yourself in that scenario where you have to do this and walking yourself through, hey, this is what's next. This is what's next. This is what I'm going to do after I get the baby out, and working yourself through that over and over and over again. And especially doing it in a way where you're constantly spacing out that repetition, it's only going to help set you up for success. So I tell them, hey, every single month, I ask myself, what halo procedure am I going to mentally rehearse in my mind so that in the event that I have to do it, I'm going to be ready to be able to do it, as opposed to trying to pop open a video or doing something else, because that's really not the time, especially when you find yourself in that really unique position. Any thoughts on cognitive offloading, Scott?
We have medical school rotators, and every so often one will come, and this has been pretty persistent throughout the decades I've been doing this, and they'll say, yeah, emergency medicine seems great, but, I think they're too much of a cookbook medicine specialty. They're always using these algorithms and checklists, and, I want a specialty I could think of, think in. I want one where I'm really forced to be making decisions, and they just are so completely diametrically off base. The reason why there's so many of those things in emergency medicine is there's just too many decisions for anyone to be able to safely make in the course of the things we have to do. So when you have the opportunity to not make a decision, take it. Now, there are going to be all of these cognitive offloading things like algorithms that are someone else's externalized heuristic. That's what essentially they are. They're trying to take an expert, externalize the things they would be doing intuitively, and then put them out there so that people can follow them. That's great as a foundation to build, but it shouldn't be you shouldn't be doing ACLS 8 years into your career. That's a problem. What you should have been is you built on that, and you now have your own ways, your own evidence that you have accumulated. You're always going to be more up to date than the AHA is. The way you do things, all of the ways of actually translating those things, all of that should be accumulating in your brain to the point where you have your own internal algorithms. But some things that are done infrequently, like pacemaker placement for most ED docs, there's no shame in having a just-in-time checklist that someone else is going to read into the room and say, okay, now put on the sheath before you insert the pacemaker into the cordis, because otherwise, you're going to start pacing the heart and realize there's no sterile extension, and you're going to look like an idiot when you send that patient up to cardiology, or you're going to have to redo it again. So that kind of stuff, there's no shame in it. You have so many decisions in the course of the day that any form of cognitive offloading that you could take should be taken. I am a huge fan of checklists for things like intubation. I don't need the checklist. We do the checklist every time. It's a pre-commitment, as you mentioned, because it builds up expertise in the room, and it's getting the reps in for me so that when I am stressed in CT scan with none of the equipment I want, that's when that checklist is going to have been so internalized by doing it the 100 times that year that were unnecessary, that now when I do need that, it's been internalized to the point where I could just rattle off the items in my head. So that's why you should take every opportunity for cognitive offloading you can. If there's a way to decrease in decision density, take it. And in emergency medicine, I watch so frequently that people are making the same unnecessary decisions time and time again, like transferring a patient to like the hospital. You only transfer, like to the peds trauma center, you only do it once every 3 months, and they're reinventing the wheel. They're calling the administrator. They're asking all these questions, when if they had just learned to do it once and written it down and put that on a Google Doc or something so that it is just there for them again 5 months later, all of a sudden their decision density for that shift or that hour dramatically decreases, but people don't do it.
Yep. And I also think about it from an educator standpoint. I think this is something that we almost have to get better at teaching, especially younger learners. I can already think of like countless examples where I'm helping an intern run their first code, and all of a sudden they're calling out, "Hey, it's been 2 minutes, and now's the time for a pulse check." And I'm like, brother, tell the nurse to tell you that so that you don't have to focus in on that, so you can start to develop your own internal algorithm of, hey, this is what I need to start looking out for to try to see if I can get Ross back. These are some of the reversible etiologies. The nurse can tell you when it's time for epi. The nurse can tell you when it's time for a pulse check. Delegate and offload some of those tasks so you can focus in on what you need to be focusing on. Same thing with pediatric resuscitations that tend to be very difficult from a mental standpoint to be able to kind of figure out, hey, I need to get this equipment ready, this equipment ready. Try to offload some of those tasks so that you can focus on what really matters. And I think that's actually
Absolutely.
a really fantastic overview. So now this brings us to another topic. And this is something that every educator has seen, especially early on in their training. When residents begin building confidence in procedures, what ends up happening is it's really easy for the identity of what I call the doer to start to eclipse the identity of the thinker. The best clinicians, in my mind, aren't defined by the number of lines or airways they've done. They're actually defined by the humility that they have in the face of uncertainty. Scott, you've spoken countless times about the dangers of procedural bravado. How do we help learners replace that impulse with cognitive humility without taking away their confidence?
Yeah. One way is external benchmarking. And I think this is something that really needs to be instilled into emergency medicine. I think it's somewhat there in the surgical world, but we're not doing it as much. And that really, for me, means you're not a good intubator because you think you're a good intubator. Everyone in emergency medicine thinks they're a good intubator. In fact, like there was a community doc who wrote a really nicely, crafted message to me saying, why are you always talking about this difficult airway crap? I have no problem with airways. I've never had a problem in my career. And, I open the mouth and stick the tube in. I don't know why you make such a big deal about it. And, it's on some level, it's frustrating because I know, that the person is not externally benchmarked. But on the other level, it's great that he has that confidence. And always, it's a he almost all the time in those cases. But so external benchmarking would be like start tracking your number of intubation successes. And intubation is a perfect one because if you're getting 85% of your tubes, which sounds pretty good in most realms of the world, you suck. Like you are a horrible 85%, which is like this great number, like is horrible, right?
Yep.
And if you're 90, okay, you're probably at the bare minimum for what we consider acceptable. And really you should be 95% or above. That's the mark. You can't feel the difference between 85 and 95 unless you're actually writing down, all right, intubated today, first pass success, no desaturation, et cetera. And if you're not tracking that, you're just going to blame that one that you got bad. It took 3 attempts and, you were already calling for anesthesia. Oh, that was just a really hard patient. Your mind immediately stops processing that of your intubation skill because you have fundamental attribution error, that one out of your brain. And so you really, really need to externally benchmark. And for things like central lines, it really means find the attending, for learners that is best at this and ask them to watch one that you do and just say like, look, I want every tip or suggestion you could give because it feels like you're good at central lines until someone really watches, not the crappy procedural, supervision watching that, is most of it, which is just, if I'm doing that, which I don't try not to do, it just means I'm trying to make sure you take the wire out before when you say all's good, that the wire's actually on the field, right? Like that's the level of most supervision after you have a basic feeling that they know what they're doing. But if you say, look, no, I want you eagle-eyeing this procedure and giving me every tip possible, rip me down, that kind of openness to criticism will build an incredible procedural expertise that's just not going to be done otherwise.
Absolutely. And this is something that I try to echo to some of my seniors, where there was one senior in particular, I remember he was putting a chest tube in. I walked in and I sat through the entirety of the chest tube. And afterwards, he's like, hey, out of curiosity, was it because you didn't trust me to do the chest tube? I'm already signed off on all these. No, man, it wasn't a matter of trust. It was more so, what can I teach you more that you potentially might not know, and also help you talk to you about some of the nuances, like, hey, you can dilate this a little bit better. You can secure this chest tube a little bit better. I know you know these things, but I can teach you some of these little micro skills that can potentially help set you up for success. Because when I think of the trap of procedural identity, I think a lot of people sometimes kind of don't really understand it. But the idea there is, again, that you have so much of an emphasis on the technical side of things that you tend to almost not understand the macro picture that's happening in
Yeah.
front of you, right?
Yeah.
And the airway example is a perfect one, right? Like, oh, I have an 85% success rate. Or I'm sure you've probably been in this situation where they call a rapid response up there. Somebody's already at the head of the bed and saying, hey, I'm going to intubate. I'm the best intubator here. And then you look at the blood pressure and the blood pressure is 50/30. Hey, I know you can intubate. That's not the issue. It's more so the whole picture. Do you actually see that whole picture? And quite often what ends up happening is that people are so fixated on the technical side of things that they tend to forego the entirety of what's happening around them. And then they lose out on that patient-centered approach that really needs to be considered, especially in critical moments.
Because what we've just spoken about is a macro theme for all of this, which is we breed competency in emergency medicine residency, in procedural skills, in decision making, and that's where you'll leave emergency medicine residency if all you're doing is showing up to emergency medicine residency. And mastery is a much different goal. And if you don't have that goal, you will never achieve it. And even having it, if you simply show up, it will never be achieved, probably throughout your whole career, because that mastery mindset needs to be built early and continued throughout. So when they're signed off on that procedure, they've gained competency. They haven't gained mastery.
Yep.
And that's really what every EM resident should be shooting for.
Absolutely. And I echoed that to a lot of my seniors that start giving away airways. I'm like, hey, how many have you done? 35. I'm signed off. I'm like, listen, man, 35 is enough to be competent. It is not enough to have mastery. You have to do a lot more. You have to put yourself in difficult situations so that you can actually develop those skill sets. And I think a lot of this points to cognitive humility, right? Where we're acknowledging, hey, we have certain limitations that we're working on, that we're striving to be better at. That's really going to help us in those high stakes, time pressured environments. So we've established this principle. And now this humility is naturally going to lead me to my next question, which is the next major piece of the mindset, and that's reflection. And I'm not talking about those check boxes or those M&M summary slides. I'm talking more about a deep cognitive review that actually changes future behavior. And I want to really pick your brain about what your process is. So let's say a case goes well or goes badly. How do you break it down? And what does meaningful reflection actually look like for you?
Sure. So if you have the bonus of knowing what it actually turned out to be, what the actual outcome is. Because a lot of times we're still working in the gray at the point you're reflecting. You sent them up to the ICU, you go home, you want to reflect on that case, but you don't actually know. They haven't differentiated to what it is. That's harder. But if you know, then it allows for some backtracking. The thing at this stage that I reflect on most is what I call BIDGO, which are bad decisions, good outcome. These are the most dangerous thing in emergency medicine. Because, and to just go back to the airway example, a BIDGO would be you get the tube in, but you didn't have proper visualization of the glottis. You didn't actually lift well. You weren't engaging the ligament. So, you never really got the epiglottis out of the way. And yet you still managed to get it in, pretty much through blind luck. And your brain is giving you, internal high fives, because that's what happens every time you successfully. But that's the most dangerous thing, because what you're internalizing is you have the feedback reward for the wrong set of actual actions. So now your brain is high-fiving. It's going to reinforce that same sloppy approach. Now, writ large, that could be analyzed from any form of emergency medicine resuscitation performance. So if you did a trauma resuscitation and the team communication was garbage and people were yelling at each other throughout the room, and yet you managed to find the tension pneumothorax and relieve it and then send that patient, safely up to the operating room, again, internal high fives. But that is a case that should be reflected on just as strongly as one that went badly, but they're not so often. So looking for that is one of the key moves for that internal reflection. And we all are going to reflect on the ones that went wrong, but a lot of that reflection is going to be beating ourselves up, and that should just be completely eliminated, unless you came to work drunk or something stupid like that. So don't waste the cognitive bandwidth on the recrimination. At the moment in time, you couldn't have done anything differently than you did. There's no possible way, given the set of stimuli, you could have done anything differently. So you relieve yourself from that, which is, this real mental move that you have to learn how to do. You relieve yourself from that, and then you start doing the mental rehearsal we talked about of like, okay, where did the path diverge that sent me down to the eventual place we wound up that I didn't want to be? And then you'll find it. And then you could start working through where your scripts went wrong and how you're going to alter that in the future. For the good cases, it's just a matter of why did things go well?
Mhm.
Because it's that same thing. There was a set of stimuli that led things to be this smooth, good interaction with easy decision making. All right, well, what were the niduses that actually led to that? And that reflection as well will allow you to build in, okay, well, I'm going to do that again. I tried for the first time doing that signposting, where at the 10-minute mark, I said to the team, hey, here's what I actually think's going on. Does anyone have any opinions? And all of a sudden, the entire complexion of the resuscitation changed. Okay, I'm going to do that every time now. I heard about it on a podcast. I wasn't doing it. I tried it. It was amazing. Now I'm going to do it every time. So yeah, reflect on the good, reflect on the bad, but do it with a cognitive framework that actually gives you the information you want rather than just being self-recrimination.
Absolutely. And one of the things that one of my mentors imparted early on me was the idea of the cognitive autopsy. And I think you kind of just alluded to that, which it tends to differ from like a traditional root cause analysis, because when you think of traditional root cause analysis, you're talking about systems issues. Whereas a cognitive autopsy is more so predicated on trying to figure out why you did something. Was there any biases at play? Were there any covert thinking process that you didn't directly observe? And the idea here is you're trying to evaluate where your judgment, where your assumptions, where potential biases were that potentially caused you to be astray, right? So great example would this be is, let's say you got like a 60-year-old gentleman that comes in with undifferentiated shock. Patient's febrile, hypotensive. You're thinking, okay, this is sepsis. I'm going to start broad spectrum antibiotics. All of a sudden, patient deteriorates. You start doing CPR. You put the ultrasound probe on, and you're like, oh my God, there was a massive pericardial effusion. And a lot of this was actually cardiogenic shock from the fact that their papillary muscle ruptured, right? So the traditional root cause analysis would be as well, the ultrasound machine was in a different room. It was tied up. Staffing was limited, so we couldn't get our EKG early on or something else along those lines. Whereas a cognitive autopsy, it's going to be built and predicated on the idea of how you thought this was sepsis, right? And why you didn't get to the idea this was cardiogenic shock initially, right? So initially I saw the patient, I was anchoring on the idea that I saw a fever, I saw hypotension, I immediately latched on to sepsis. And then I got more confirmation bias and I chose to ignore some of the other things like JVD, cold lower extremities on exam, because it was discordant with what I was initially thinking about, right? So I think that's actually been something that's really, really helped me from my standpoint. Are there any other reflection tools that you've used that have helped you?
You know, it's less a reflection tool than a teaching methodology, but shadowboxing from Gary Klein, who, is my hero in this space of resuscitation mindset, even though he's not a resuscitation thinker per se. He works with all sorts of chaotic industries, fireground, surgeons, etc. But shadowboxing really is, you take a case that has a lot of cognitive pitfalls and you give it to a learner, and you have stop points where you say, okay, what are you thinking and what are you going to do at this moment? And then you actually reveal what an expert would do. That could be you. It could be someone, who's a real expert in the field. And then that gives them the capability of kind of pre-dissecting these errors that would occur. They're like, oh yeah, well, that patient's obviously septic, so I'm going to give broad spectrum antibiotics. Oh, and then you say, well, actually at this moment, the expert resuscitator was saying, oh, something's anomalous here. The patient's extremities are ice cold. Right? Like that was their anomaly point. And they're like, well, now that I told you that the extremities are ice cold, what does that make you think? How is this discrepant from what you just said? And then you keep playing out the case, stop point, ask them what they would do, force them to commit, right? This is another form of commitment, but then tell them what an expert's thinking at that moment and what the expert did. And this technique is so powerful for actually building the skills of that cognitive reflection you were talking about.
Awesome. I love that. Now that we've established this mindset, this decision architecture, humility, reflection, I'm going to ask you a kind of a broad question, and you might not have the answer to this, but how do we teach this to residents? How do we take these decades of lived experiences and wisdom, and how do we translate it into something that a new intern can grasp and apply?
It's a little dispiriting to say this, but it just really has been beaten into me by my experiences, which is, in some ways, this is attitudinal from the learner. And there are some learners that just crave this stuff, and teaching them how to do this becomes very easy because they'll fill in the gaps if you start feeding them even, the broad outlines of all the things we've been speaking about. They'll come back to you with questions asking, okay, I don't quite understand how to do this cognitive autopsy. What do you really mean? And it's so easy. And then there are the learners who And, I actually heard one of my residents say this out loud, and it wasn't even surreptitious. It was like amongst, 3 attending, she said, "Yeah, when I get home, don't wanna think about emergency medicine at all. I'll do my shifts, and then I am free when I get home. That I have other hobbies in life I do." And I'm like, "There's no way I'm going to be able to teach this stuff to that learner. I'll try. I don't give up on her, but the chances of her really internalizing all the things we've been talking about is very slim because she doesn't have a metacognitive approach. She doesn't want that metacognition. She doesn't want to spend time thinking about it. And so, if their attitude is there, then we will be able to do this with great ease. If the attitude is, I don't want any reflection time, that's mental space that could be better used somewhere else, you're not going to win. I guess the hardest part of that question is these middling learners
Yeah.
who they have a pretty good attitude, but they're not the ones who are going to just pull you along to what further information you need. And I don't know. I think you just lead by example. Like if you had a real hard case and then you tell your learners, all right, tonight I'm really going to be doing this cognitive autopsy on this. And they might, have some curiosity. What does that mean? And you could actually tell them. But yeah, it's really hard when they're not prepped and primed to be able to want this essential curiosity.
Yep.
When that's not there, it's kind of hard.
Absolutely.
What do you
And
think?
I think I've struggled with that as an educator too, where after we're debriefing at the end of a shift, and I'm like, you know what? I don't know if this individual is going to have that metacognition to be able to understand everything that we've just talked about and or reflect on some of the unique experiences that we've shared over the last 8 to 10 hours, right? So where does that leave me, right? Because the next shift that I work with them, I ask myself, okay, I'm basically starting from point zero as opposed to building on something that, because I have limited time with you, I work one shift with you every 2, 3 months. I want to make sure I'm maximizing that. So if you're actually taking the input that I've given you and you're reflecting on it and you're building on that, then I can keep making that foundation stronger, right? It's like you're building a house. If the foundation, the beams aren't right, it's going to collapse on its own right? So you have to have something there. So Scott, as time is starting to wind down, I want to bring this back full circle, right? We started with this idea that the most powerful resuscitation tool isn't a device or a drug. It's your mindset behind the hands that are making the decision. So before we close, I'd love to ask you, if every new EM resident could walk away with just 3 core lessons from this episode about how to think in resuscitation, what would they be?
Ooh, okay. I guess number one is that metacognition we spoke about, which is always be thinking about your thinking. It's the only way to build stronger thinking. That's essentially what metacognition means. It's that true desire to analyze your processes, whether before they happen or after, to actually look, is my mindset good? Because the problem with letting it happen organically is all sorts of errors creep in. You have bad heuristics, you have horrible illness scripts, and unless you're really thinking about it, they don't get fixed. So that's one lesson. The second lesson is meditate. And I will say this, and no one's going to do it, but it really is the most potent tool to actually have a capability of exploration of your mind and a essential improvement of all of the things that go into good resuscitation mindset. But no one's going to listen to me. And then remember, because it is the driver to all of this, that we are in what I think is the best profession available in the world. That we go to work every day and we get paid, and admittedly not much at the learner level, but it gets better, to have a truly noble profession. We get to take care of patients when they're at their worst and bring them back to a state of health. And sometimes, once in a while, we get to save their lives. So that essential purpose should drive all this and really leave you with a feeling, no matter how hard it gets, that you're doing something incredibly important to the world.
I love that. That's actually awesome. Speaking of the meditation, are there any resources that you recommend for young learners that are interested in starting their meditation journey that you found to be helpful?
The book I'm going to recommend is a lot. It's a lot. So don't get scared by it. You just read tiny chunks and then you come back. But it's written from a true scientific, it's written by a teacher who's also a neuroscientist. So it's really up the alley of medical folks. And so I recommend it, but don't be scared off by it. Just read a little at a time. It's called The Mind Illuminated by Choldasa. But it's spelled like you would think it's pronounced Coldasa. So, Culdassa. And it will take you through the breath following method of meditation, but give you all the neurocognates to all of it. And I think it's a wonderful book. But the real answer is get a teacher if you get interested in it. Like if something gets sparked and you're like, I really start liking this, or as early as possible, just find a teacher, because there's so many bad habits that get instilled by self-teaching.
Gotcha. Excellent. And what I'll do is I'll actually include that in the show notes. So for
Great.
anybody that's interested in starting their meditation journey, that sounds like a great resource to start. So I'll include that. So as time's running low, Scott, I just wanted to say thank you so much for joining us. Really, really appreciate your time. This is such a fun conversation. And for me, this conversation is really a reminder that the real work of becoming a resuscitationist starts long before we ever touch a laryngoscope or place a central line. It starts with this mindset that we bring into the room, right? It's about how we prepare, how we make decisions, how we thrive under uncertainty, and how we learn from cases that truly shape us. For everyone listening, I hope today's discussion gave you tools, not just for managing critical moments, but for also understanding your own inner architecture as a clinician and also as an educator. If you can cultivate cognitive humility, deliberate reflection, and clarity of thought under pressure, I promise you, the skill set will follow. If you want to explore more of Dr. Weingart's work, check out MCRIT, check out his podcast, check out his hundreds and hundreds of talks that have shaped so much of the way we teach and practice resuscitation. They've definitely shaped my own. Thank you so much for spending part of your day with us. My name's Dr. Irtaza Asar, and this is The Learning Curve. We'll see you next time. Until then, stay learning.